At this point, I want to thank yet another team of experts from Stanford who've come to share their time and expertise to support you in this journey. I've already introduced Dr. Kathleen Poston yesterday. She's back. And I'm going to leave her to introduce her team, and she's going to facilitate this session based on questions that you submitted during your registration process, but we will then again do more Q&A like we just did in the last session. Okay? So Dr. Poston, I will turn it over to you.
What we're going to do here for this part is I have a collection of specialists that I very commonly refer to patients who, or physicians who refer patients to me. There's a lot of back and forth between the members of this team and neurology and folks like them out in the community. And so I'm actually going to go through first just letting them introduce themselves in the sense of who they are, what kind of training do they have, and what's their connection to MSA? What is their role in treating patients with MSA? And I'm going to start to my left here with my colleague, Dr. Santini, who is a movement disorder specialist from Stanford.
Thank you, Dr. Poston. So I'm Veronica Santini, and I'm a movement disorder specialist. And what that means is that I did extra training after my neurology residency to focus on specifically movement disorders. Now, every movement disorder fellow has kind of their own niche that they like and that they work on. And so I had specialized training in autonomic disorders, and so I focus a lot on multiple system atrophy, as well as some other conditions. One of them being ataxia, which is often a way that multiple system atrophy can present. I think that's about it. I'll pass on.
And next we have one of our urologists from Stanford.
And so my name is Ekene Enamchukwu, the really long one, really long last name there. So I am an assistant professor in urology at Stanford, and my training was in urology, and I too have fellowship training specifically in pelvic floor reconstruction surgery and neurourology and voiding dysfunction. So a lot of the patients that I see in my practice have some type of neurologic condition that also affects their urinary tract in one way or another, or their pelvic floor. And so those are a lot of the patients that I see in common with these guys.
Great. And next we have a representative from GI.
Hi, and I am Leila Nishatian. I'm a gastroenterologist. I have done my fellowship at the Mayo Clinic with a special interest in neurogastroenterology, which is focusing on the motility disorders. And I see majority of the patients with motility, including neurological disorders, that they have functional GI disorders, including motility disorders. I have been also having extra training in pelvic floor disorders. And these are definitely the patients who have a problem with defecation, and including constipation, irritable bowel syndrome, and these are very common conditions in patients with neurological disorders, and I'm interested in seeing these types of patients. Thank you.
And the last member of our panel is representing cardiology.
Hi, I'm Dr. Karen Friday. I'm a professor at Stanford. I also am acting chief of cardiology at the Palo Alto VA. As an aside, before I describe what I do, to remind any of you that if you are veterans, that one of the things the veterans does offer is respite care to help with caregiver relief as well. So for anyone who has VA eligibility, they have resources not only for patients but for caregivers as well. I predate any subspecialty training, but I had excellent training in internal medicine at Johns Hopkins Hospital in exciting Baltimore. I did my cardiology training and with one of the first women who actually was in a program in electrophysiology. I see primarily at Stanford patients who have orthostatic tachycardia. I also and we'll get into this more later, but it's my impression that often people with autonomic dysfunction, they may not move so well, they may feel a little weak, but it's when they feel dizzy or feel faint that they're seen, and that is often the first point of care in cardiology.
Great. Thank you all so much. So, Dr. Friday, since I have your slide teed up next, I think it's a really good introduction to why we need this interdisciplinary team for people with MSA. So, why don't we go ahead and start with your explanation here.
I'll let you click through.
I will click through. Tell me when to click. So go right ahead.
When I give talks about autonomic dysfunction, I often start with an Indian fable where 7 blind men encounter an elephant. They're subsequently asked to describe what did the elephant look like. And the first, so click. So the first person who got the trunk said it looks like a snake, feels like a snake. The next slide. The person who had the trunk said it feels like a spear. The next. The person who had the ear said it feels like a fan. The one who had the legs said, well, it feels like a tree trunk, a great big tree. The person who was feeling the side said, well, it feels like a large wall. And the person who had the tail said, well, it feels like a rope, something that I would tie something with. So each one of these people were accurate in what they were describing, but none of them would lead you to be able to recognize an elephant. And that's what I tell the autonomic dysfunction is that because there are so many pieces, that it takes a real skill to put the pieces together to come up with the evaluation for autonomic dysfunction, because as Dr. Miglis described, the autonomic system involves every part of the body.
I love that description, because I think that what we're trying to do here collectively is put the elephant together. And this is one of the reasons why I oftentimes will tell my patients one of the most important things is communication between your team. So it's great to have a team of experts, but if they're all looking at the elephant from their perspective and they're not talking to each other, they might come up with this answer, and they might see you in little pieces but not be able to put that whole picture together. And the way that we transition from being the blind wise men looking at the elephant to actually seeing the elephant as a whole oftentimes is through communication between your team. So please always make sure that your doctors are sending each other notes and that things are communicating back and forth, because it's very important. So let me throw this question to you, Dr. Santini. So as the movement disorders specialist, once you have diagnosed a patient with MSA, tell me some situations when you start to think about this team idea. Who else might be needed on the team? Do you have the exact same group of specialists for every patient with MSA, or do you have to think about it in a more complex way?
Absolutely not. We don't have the same team of specialists. But let me just take a step back. This can also be a reason, this elephant example can also be a reason why patients with MSA have so much trouble getting diagnosed. Maybe a neurologist is saying this looks like Parkinson's disease, and a cardiologist is saying this is something abnormal with your heart rhythm, right? And so until you get the specialists who are able to kind of put everything together, it can be a very difficult diagnosis. This is another reason, this idea that really a team of specialists together is how we treat the patient most comprehensively. This is another reason why it's important to have a very good primary care physician. They can be very helpful stewards of coordinating the care between all of us, and then insisting that we all communicate as well. So if you feel like things aren't being communicated very well with your specialist, really talk with your primary care physician to help coordinate all of that care. So back to the original question, when do I really see that we need a team involved? Oftentimes when we're first getting the diagnoses in place, unless the patient is in a crisis or having really severe symptoms, we really just want to establish that relationship. So the first visit, we might not be suggesting that we get the entire team in place, but as things come up, it becomes more and more important for me to make sure that I'm not missing anything else. So oftentimes patients are complaining to me about urinary symptoms, frequency, urgency, incontinence, and while I can start very basic medications that might be safe for the patient, I really do utilize our amazing urology specialists because there are other things that might be going on. Is the patient a female and has had children? Is the patient a male and might have some prostate enlargement? I don't want to assume that I always know everything medically about the patient. So whenever I'm feeling that a symptom is becoming more severe or that it is sort of at a higher level care where I may have the potential to miss something, I really do call on the other experts. Teams that are involved in patient care include all of the specialists you see up here, but others as well. And that includes some of the conservative therapies such as physical therapy, occupational therapy.
So let me throw this, since you brought up urology. If you do refer somebody to a urologist, so they show up now in your office in urology, what might somebody expect as an MSA patient being referred over to a urologist? And I'm going to pull up your picture here. I'm going to come back to the other one in a minute.
Absolutely. So the visit generally starts with just getting to know each other. So I want to know all of your history. As Dr. Santini just mentioned, there are anatomical things that can be causing your symptoms. It could be related to your neurologic condition, could be unrelated to either of those things. So I start by just getting an idea of what symptoms you're having, how long they've been going on. Let's get a timeline of what's been going on. Then we do some simple tests, starting a lot of the time with a urinalysis. Check, make sure you don't have an infection, blood in the urine, something else that could be contributing to your symptoms. We often will get an ultrasound, have you go and urinate, empty your bladder, get an ultrasound, get a sense of how well you're emptying your bladder. We do that right in the office. And then a physical exam. So the physical exam is often very helpful, again, to look for anatomical causes such as an enlarged prostate. Women that have had babies often have some pelvic floor changes that can contribute to frequency, urgency, incontinence. So we want to make sure that we've addressed those things and then see what symptoms you have after we've addressed those issues. So after we've done that, if we find that this does look, your symptoms do seem to be related to your neurologic condition, then I generally recommend some further testing. And so that further testing is a bladder function test called Urodynamics. So it's a test where essentially I am filling the bladder with some water and I'm measuring the pressures and the function of the bladder. And then you're asked to use the bathroom, so to evacuate, empty your bladder. And then we get a sense, an overall sense of how your bladder works, how your sphincter works. So is it controlling things the way it should? And then also, is the sphincter relaxing when it's supposed to? So often the issues, the symptoms that you're having are due to a combination of issues with the bladder, the sphincter, and other things. So the picture I have up here is a picture of the urodynamics room. And it looks a little scary looking at this picture, but trust me, it's not as scary as it seems. But basically, this equipment that we have up here is just we take some X-rays of the bladder as it's filling up with water. We want to make sure that the bladder has a normal contour and that it looks normal in shape. We also want to make sure that there isn't urine that flows back up to the kidneys, and it's really important to determine whether that's happening because that can ultimately cause damage to the kidneys. So the last thing we want is on top of your MSA to be dealing with kidney function issues. So we want to catch that early and prevent that. The equipment here also shows a little chair, so it's just a comfortable chair that you sit in there as the test is being performed. And then I'm always in the room throughout to talk you through everything and to tell you as the test is going on what I'm finding. And then at the end we spend some time and I piece everything together from our discussion, physical exam, the test, this bladder test, and then tell you what my recommendations are. So with neurologic conditions, as Dr. Santini said, she doesn't use the same team every time because every patient with a neurologic condition, even with MSA, is a little different. And so we need to prepare an individualized plan, management plan for managing your specific urinary symptoms.
Thank you. And I have to say, when I first saw this this slide and this equipment, as a physician, I realized how completely inadequate as a neurologist we are in really diving into what is causing a lot of these urological problems, and that we really do. It made me realize how much we need the urologist's input to figure this out, because we just, as a neurologist, we just ask the history and we stop there, whereas everything past that, the physical exam, the specialty tests, none of that can be done in a normal neurology clinic, and we really need the specialist for that kind of work. So similarly, with some of the blood pressure and cardiac workup, when a patient might be either referred to you, Dr. Friday, or if, let's say, they come into you the first time complaining of lightheadedness or dizziness, what are some of the specialty things that you might do in your clinic that is really trying to get at the heart of what is going on? And I can pull up. Oh, there we go. Yes, here's your slide of some of the things that you look at to try to unravel this mystery.
One of the things I'm sure many of you have found is that the symptoms can get worse if people stand. So they present with providers with complaints of orthostatic symptoms, and yet prior providers, be they internist, cardiologist, primary care doctors, never do the test that Dr. Gerarde said and just measure heart rate and blood pressure. I actually had one physician who was an internist, and his daughter had been treated for panic disorders until he finally decided to take orthostatic vital signs and found that her heart rate went to 134 when she stood up. So we believe that she might have something more than a panic disorder. One thing that is evolving is technology, because from my perspective, one of the things that is missing is a really good continuous blood pressure monitoring. Dr. Miglis and Gerarde and their colleagues have the Finepress, or the finger blood pressure monitor, that they can use on a tilt table test. There are 24 or 48-hour blood pressure monitors that are used, which are cuff blood pressures, but often the mechanics of the cuff being inflated and deflated can change. But with more technology being developed, that hopefully the availability of continuous home blood pressure monitoring will be available. The alternatives are various ways of heart rate monitoring. The Holter monitor measures heart rate, but only over a 24 to 48-hour period. A Zeo patch has no wires attached and gives 2 weeks of recording. One of the drawbacks of that is that the real-time monitoring is still being developed. So if someone has a clinical event wearing a Zeo patch, they put it into and mail it back to the central monitoring station. We had one patient who had a 12-second pause, felt lightheaded, dizzy, and we knew about it 10 days later because he continued to wear the patch for another 8 days and then mailed it in. Event monitors do involve wires, but they also can Bluetooth. So that's like the emergency telemetry that you may have had in the hospital, where if there is a change in heart rate, that can be recorded. For people who are fainting, but it's infrequent, there are implantable loop recorders. Initially, they were the size of a thumb drive below. Now they are much smaller and can be injectable. And those stay active for up to 3 years and have the capability of Bluetooth monitoring so they can detect a symptom. One of the challenges with the heart rate in autonomic dysfunction is that very often it is not an arrhythmia. It is not an abnormal heart rate. It is an abnormal pattern of a normal heart rate. So when I have patients referred, and often from other cardiologists, I like to see not only the front sheet that says heart rate range 39 to 180, no arrhythmia is detected, but also the pattern of whether it's an inappropriate sinus tachycardia, whether there's a marked orthostatic change in tachycardia, or whether the heart rate is blunted, whether over the 24 hours the heart rate is the same and is a flat line regardless of what activities the patient may be doing. So one of the things that the data provides is a lot of insight into components of autonomic disorders, but often cardiologists don't read that. They're looking for an abnormal heart rhythm and often miss the other signs that suggest an autonomic dysfunction.
Great, thank you so much. It's really, again, remarkable how much technology has helped us to understand what happens to the heart and the blood pressure outside of the clinic room. You can imagine, we get that one blood pressure and that one pulse rate when you come and see us in the clinic, but so much happens out there in the real world, and a lot of these technologies are now helping us to understand that, to be able to treat patients better in the real world. But we really need experts in autonomic and cardiology to help us interpret what all that means. So I'm going to turn our attention now to the often under-recognized but oh so important GI tract. So one of probably the most common disorders as part of MSA, and really a lot of our neurological disorders, is constipation. And I think a lot of people think this isn't such a big deal because, everyone's gotten constipation sometime in their life. But I have found that when a patient is constipated, their whole system is completely out of whack. And their walking is worse, their balance is worse, their sleep is worse. It's really, their blood pressure is worse, right? Absolutely. Their blood pressure, their bladder's worse. It's one of those things that when it's out of whack, everything is dysfunctional, and it's also a hard one to approach because there are a lot of over-the-counter remedies, and so people think, I'm just going to go and get some over-the-counter Colace and that'll fix this. But I think it's a lot more complicated than that, and so I often need the input of my GI colleagues to unravel this. So if you could explain to us a little bit, when patients are, this is obviously not something that we can just handle with some Colace and some Senna, and we send them for a more thorough evaluation. What might the patient expect, and what are you looking for?
Sure. I'm glad that this is emphasized, that constipation is often an overlooked symptom in many patients because it's very common in the society, but we know that this is really affecting all the other organs, and it's really can influence the quality of life, not only because of the bowel movements, but also really the management of the baseline disorder as well. So the major causes for constipation, there are 3 types of the constipation that are really commonly seen in patients with neurological disorders. One, it can be because of the slow transit constipation. It's just because the colon is lousy, doesn't have enough contractions, and so as the result of this, we have a slow transit constipation. This is often see in patients with neurological disorders, but it's not really the only cause of constipation. The second, more important and even more common than slow transit constipation would be pelvic floor disorders or dysenergic defecation. So what is dysenergic defecation? Defecation, the act of defecation, elimination of a stool, is really a very important part of stooling or having a bowel movement. And this requires not only good pressures in the colon, but also relaxation of pelvic floor and anal sphincters. If this doesn't happen coordinated at the time that you are trying to have these pressures in the colon to eliminate the stool, if you are not really relaxing the pelvic floor, really coordinated with these contractions, this condition is called dysenergic defecation, is incoordinated defecation. It can be seen in more than 50% of patients who have Parkinson's disease, and it's really common. Sometimes it's because of really dystonia as well, that because of the dystonia in anal sphincter or the pelvic floor, you can have this problem with elimination of a stool. So how can we really go and evaluate these conditions and really see if we can figure out what's the cause of the constipation in a patient with neurological disorder? For slow transit constipation, we have very cool tests. One test that is often used is called the SMART pill. So this is a really smart pill. It's as big as a big vitamin capsule, maybe. You have to swallow this pill, and then you will go home after you swallow this pill with a device that is a recorder. Every time you eat, you go to bed, you take a shower, you will basically push a button on this device, and after 5 days, you will return this recorder to us, and we can evaluate how long will it take for this capsule to go through your system in the GI tract. So this smart pill will give you a good understanding of the transit time. How long did it take for your colon to pass this capsule? If it's more than 60 hours, this is considered slow transit constipation. So it's an easy test, doesn't really have any radiation, doesn't really have any cautions that are commonly seen with this. How about pelvic floor disorders? I don't have any pictures. One, it was because I felt that these pictures can be daunting if you don't really review them in detail. And two, because there are so many different tests that we can do, and so it wasn't really easy for me to pick up a couple of slides and really review them quickly. So in terms of the pelvic floor disorders, we have anorectal manometry. These are pressure sensors that can really evaluate the coordination of the rectum and pelvic floor or anal sphincter muscles at the time of elimination. So this will be a test that you will be doing without sedation. You will be basically lying on the left side. This catheter, which is really small catheter, maybe the diameter is not really more than the writing pen, will be also the length is not going to be more than a writing pen, will be in the rectum. There will be a balloon tied to the tip of this catheter, and then we will ask you to mimic defecation or elimination at the time that we are recording the pressures in the rectum as well as the pressures of the anal sphincter and pelvic floor. At the same time, we can also, with the balloon that is inflated in your rectum, we can get an understanding how good can you really feel this the presence of a stool in the rectum. Maybe there is a stool there, but you are not just getting the urge because the neurological dysfunction has affected the rectum, and so that's the reason for you not to really know that this is time for having a bowel movement, because the urge sensation doesn't come on. So we can get really a lot of information about the dysenergic defecation and the sensation of the rectum with doing anorectal manometry. But often we see patients who are not really coming to us because of the constipation, and they will be coming when they have really major complications. Let's say they have been having all these symptoms for years. they have been ignoring them or just have been taking over-the-counter medications such as Colace with really no good control, and now they have significant problems with rectal bleeding, hemorrhoids, even what we call rectal prolapse, that the whole tissue is coming out, and or they have been having significant weight loss because they are not able to eat, and so this has been affecting really their quality of life, and so this is what that we don't really want to happen. We want to see these patients earlier because we can offer good tests and really have very good medications to also control the symptoms of constipation. Nowadays, we have become really good with our pharmacology for controlling constipation. Over-the-counter medications are all fine if they are working and if one can really use them to have regular bowel movements. That's perfect. We can obviously use them with no hesitation. I see many patients are telling me that they are not willing to take laxatives because they are worried about dependency. But I feel that if you are constipated and you are not really having a good life because of that, it doesn't matter if you are dependent or not. You have to really take a medication to feel better and to be able to have proper bowel movement. But if they are not working, then we have 3 new medications. These medications have been on the market since 2012. One of them, the last one, was just approved last March, and they are targeting the ion channels in the GI tract. And when they are taken, they can actually draw the water into the colon and cause really an effective bowel movement with the fluid in the rectum and in the colon, and therefore causing the transit times to be much faster and improve the symptoms of constipation. Amitiza, you may have heard about it, or lubiprostone, linaclotide or Linzess, and Trulance or plecanatide. These are the 3 new medications that have been very effective. Sometimes the side effect can be diarrhea. These are very effective, very safe medications. They do not interact with other medications. They do not really pass through the blood-brain barrier. So it's not going to have any central effects. And they have been used in the GI commonly and very effective medications. So I want you to talk to your doctors about the symptoms of constipation. Do not ignore that. Yes, we can often start with fiber over the counter. These are the lifestyle modification will be the first step. But if you feel that it's not working, do not ignore the symptoms and look for help. And we have really smart technology and very effective medication to help with the symptoms.
Yeah, that was fantastic. And I really just want to reiterate that, 10 years ago, it was really the over-the-counter medications, some lifestyle modifications, and that was kind of it. Things have really changed even in the last 5 years. As she mentioned, several new FDA-approved medications for constipation. And I have to say, they're so new, I don't know them well enough or feel comfortable enough to prescribe them like I do, like Colace and over-the-counter things I feel very comfortable with. But once we move on to these newer things, especially since, as she described, there can be different causes of constipation. I'm referring my patients oftentimes to the gastroenterologist to try to figure out whether one of these new medications would be beneficial or not. So there's a lot of things we can do above and beyond what was available 10 years ago. So I think that this is a really important area to be proactive about, because there can be a lot of bad outcomes associated if we don't treat ahead of time. So while you all are listening, now that you know what all of our specialists do and what their areas of expertise are, please start thinking about those questions you want to ask, okay? I'm going to start off with some of the specific questions that people had already emailed in ahead of time, but please start thinking about those questions. I see some already coming up. Thank you very much.
From online.
Oh, online. Wonderful,
Yeah.
wonderful. Okay, so I'm going to move back to to urology. And here's a question that I thought this was a great question because I don't know the answer to it, so I want to know. So is there any kind of physical therapy or physical activities that can potentially help urge incontinence in particular? Is there non-medication, more sort of physical activity or physical therapy that can help with an urge incontinence? Thank you.
Yeah, so this is a great question. So when I have patients come in with overactive bladder symptoms, so overactive bladder being frequency, urgency, incontinence, getting up at night, that's a big complaint, getting up many times at night and not getting good sleep. I will often talk to them about the non-medical treatments of this condition before we start talking about medications. So those non-medical treatments include dietary changes. So you want to make sure that you're drinking enough water, but not too much water. And you also want to make sure that you're not drinking a lot of carbonated fluids. I know often fatigue is one of the symptoms, but caffeine is also something that can worsen your symptoms and worsen things like urinary frequency. So to take a step back, when I say urinary frequency, what does that mean? That means going to the bathroom more than 8 times during the day. Okay, so a lot of patients that have neurologic conditions will complain of that symptom. Urinary urgency is where you're sitting there, you're fine, then all of a sudden you have this sudden urge to go to the bathroom and a fear of actually having an accident. And you have no time to even think about getting to the bathroom. And then urgency incontinence is where you leak due to that. Getting up at night, nocturia, as I mentioned, is getting up more than 2 times a night. So up to 2 times a night is considered normal. More than 2 times a night, that's not normal. And so we start with looking at your diet and what you're drinking and just making sure that there isn't anything that's worsening those symptoms. So as I mentioned, caffeine, carbonated fluids, artificial sweeteners also are irritants to the bladder, spicy foods, citrus, alcohol, tobacco. Those things all irritate your urinary tract and will make your symptoms worse. So after we've addressed those things, the other thing that we address is constipation. Constipation can make your bladder irritable and also cause these overactive bladder symptoms. Constipation can also contribute to obstructive symptoms. So you get the strong urge to urinate, you jet to the bathroom, you get there, and then you can't go. So sometimes that's due to an obstructive issue due to constipation or due to something else that's neurologic as well. Or you get to the bathroom and you start going and you drip, 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 and your bladder still feels very full and it's not actually getting empty. Also very common. And so we make sure that your constipation is at least being worked on or being managed, that there's some plan for that. So onto your actual question, which is about pelvic floor physical therapy, that is always something that I always recommend as well, because it doesn't hurt to strengthen your pelvic floor. So the exercises that are often helpful are Kegel exercises. It's very easy to give you a plan and say, here, go do some Kegel exercises and let's follow up in a few months and see how you're doing. The issue is that Kegel exercises are not intuitive for anyone. Very few people know how to do them correctly, and so as part of my evaluation, I'm also evaluating your pelvic floor strength as part of our neurologic exam. And so often at that time, I ask the patient to do a Kegel. And I will tell you that 9 times out of 10, they're not being done correctly. They're contracting every muscle except for the correct one. So I take that opportunity to teach you how to do them properly. But part of the issue is often that because of your neurologic conditions, those muscles are very, very, very weak. And so that's where a pelvic floor physical therapist is helpful, because they have other instruments, for lack of a better term, that they can use to try to stimulate those muscles and try to teach you how to contract the correct muscles. So I always tell my patients that the pelvic floor physical therapist is kind of the personal trainer for your pelvic floor. They're making sure that you're doing the exercises correctly. They're making sure that you're doing it frequently enough and not exhausting or fatiguing those muscles by over-exercising them. And then they're also making sure, they're your accountability partner. So when you come back to see them again, they're checking to see whether you're any stronger or if things are exactly as they were before. So generally what they will do is teach you 2 specific exercises. One is Kegels, as we just discussed, and they'll give you a regimen on how you should do those, how many per day, how long you should hold each contraction. But they'll also talk to you about another little trick called quick flicks. Quick flicks just means when you get that sudden strong urge to urinate, you ask you to do 5 or 6 quick Kegels in succession. And what that does is actually bypass the brain, and it sends a feedback signal to your bladder to stop contracting, to relax. Okay, so it works sometimes, but again, it depends on how strong your Kegels are. If they're very weak or you don't know where those muscles are, then this obviously won't work. So it's often helpful to go see a pelvic floor physical therapist, and I generally recommend at least seeing the pelvic floor physical therapist for a few sessions. Some of my patients go for 12 sessions. They go weekly and they go for 12 sessions. And we know at the end of those 12 weeks, if things are not any stronger, they're not any better, then we really do need to talk about other treatment options. And thankfully there are a number of them, medical medications, as well as procedures. So that answers the question.
Yeah, that was fantastic. Thank you. So I'm going to sort of cycle through the teams here with a couple of thematic questions. And since we also got some questions about some definitions related to the GI tract. So when does someone considered constipation, particularly if they were regular, they thought themselves to be regular throughout their whole life, now there's some changes. At what point are those changes constipation? Is it the frequency? Is it how hard the bowel movements are? What is that point in which we sort of think there's something different here? How would you define that?
Right. So this is a great question because every single person may have a different way of basically eliminating the stool, and so they may not consider what is constipation for one to be constipation for them. But for that matter, we are using a standard criteria for functional difficulty, for functional constipation, I must say, and that considers any person who has less than 3 bowel movements in a week and have symptoms of hard and lumpy bowel movements, or they need to have significant straining at the time of the bowel movements, or they may have symptoms of incomplete evacuation, meaning that after having a bowel movement, they are still feeling that they could do better, they are not really done, and their rectum is completely not really empty, or symptoms of sensation of a blockage at the level of the pelvic floor to the level that they cannot have really a proper bowel movement. So any of these are present for more than 25% of the bowel habits, and a combination of these are considered constipation. So it's not only the number of the bowel movements, less than 3 a week, but any of these features are present. These are considered constipation. So even if they have been having these symptoms for some time, these are not normal, and these are the features that you can really discuss with your doctors and ask for help for them.
Thank you. We had a couple of blood pressure specific questions, so I'm going to shoot it down to cardiology and maybe we'll sort of go through the group because honestly these were fantastic questions that everyone came up with, some very practical things, and so let's start off with Dr. Friday here next.
I have a couple questions. One is hereditary low blood pressure a potential cause of MSA or just a symptom? And the answer is that it's, there are people who just always have a low blood pressure. They feel lightheaded and dizzy. Why some people genetically just tend to have a low blood pressure is uncertain, but it typically is not a manifestation of a more global autonomic dysfunction. It's one of the reasons why I say, despite being a cardiologist, I actually take an internal medicine style history and physical, and if there's no evidence of other system involvement, obviously people who start with a low blood pressure. So if your blood pressure runs 90 to 100 normally, that anything that drops it by 20 millimeters, dehydration, hot weather, exercise, can make people much more symptomatic than if you start with a blood pressure of 140 and it goes down by 20. But typically that, there is not an overlap. And concurrent question is it unusual for my husband, almost 8 years into apparently the MSA diagnosis, to have blood pressure issues? He also has bladder and swallowing problems. One of the challenges with MSA, and I should defer to my neurology colleagues, is I don't think anyone has a really good idea of the time course because people are frequently fairly far into the symptom development. So in terms of a time frame as to when do which symptoms develop, I'm not sure,
Yeah, so what we know is actually the pathology in MSA, that abnormal protein that I'm sure you've heard of, the alpha-synuclein. We know that that is building up many, many years before the diagnosis. So this idea of when the diagnosis starts is somewhat arbitrary because we often attribute it to when the patients are having noticeable, demonstrable symptoms that we can sort of measure and identify in the clinic and on examination. I think that because of that, you're right, we don't usually know when people are or where they are in the course of disease, and certainly that does not correlate always with their pathology. The other thing that we know very well, and we discuss all of the time in our division meetings and our discussions amongst experts, is that although the literature tells you, hey, there's this certain number of life years or time span that you'll have this disease, we know that that's absolutely not true. I've diagnosed people after them having it for about 10 years and they had been misdiagnosed all this time with Parkinson's disease, and certainly they go on to live many more years after that. So we know that there is a high level of variation between patients, and because the autonomic nervous system affects every part of the body, they can present with many, many different symptoms. And so each individual disease is different. So while you all may share similarities in this disease state, each individual person has a different disease course and length of time.
And the one other question I have is about atrial fibrillation, and is atrial fibrillation with rapid ventricular response common in MSA patients? One of the things that has been learned more recently is that there's a very high correlation between obstructive sleep apnea and atrial fibrillation. Certainly, atrial fibrillation is a multifactorial illness, and certainly there is such a thing as vaguely mediated atrial fibrillation. So, again, I don't have good epidemiologic statistics to say is atrial fibrillation more common in MSA patients, but because MSA patients may have more variability in autonomic function, may have more sleep apnea, it certainly is, I would assume, not an uncommon finding.
And also the age in which the patient may develop the disease, right? That's very common. A similar age group might be developing atrial fibrillation for other reasons as well. So just one other comment, Dr. Friday. I know, and this, Dr. Inamchukwu can attest to this, that we have many patients who avoid drinking water because of their autonomic dysfunction, because of their urinary symptoms. And so dehydration certainly can play into those blood pressure issues as well. Wouldn't you agree?
Absolutely, and it's one of the things that, again, to reinforce what Dr. Miglis mentioned, is that the Vanderbilt Autonomic Group has identified that chugging a bottle of water can increase blood pressure and decrease heart rate, and so it's one of the things I tell people to always have the bottle of water and to chug it. Also, in people who have more early symptoms of orthostasis, that sitting down may feel uncommon. I tell people you can always pretend you've dropped something on the floor and squat down and stay there as long as you need to if you feel it a socially awkward situation to ask to sit down or sit on the floor.
And I really appreciate you bringing up the water question. This is one of the reasons why we need everyone here working together, because in order to avoid seeing our urologist, you might stop drinking water, but then that causes more constipation and more blood pressure problems. So it's a battle between these things, right? And it's a balance based on your experience. What do you tell patients when they come with this kind of dilemma?
Right, so this is always challenging because, we say, don't drink too much water, but drink enough water. So what's enough water and what's too much water? The teaching has always been 8-ounce glasses of water per day, but that is really a general teaching for, and doesn't really work for every individual. It really depends on your weight, your stature, how active you are, how much you're sweating, how often you're going to the bathroom, your bowel movement. It depends how much soup you drink. It depends on a lot of things. So generally, I try to individualize that. For my neurogenic patients, or neurologic patients, I generally tell them that they need to drink as much water as their neurologist tells them to drink. Okay, you need.
I know that you say that.
Yeah, because at the end of the day, going to the bathroom frequently, we can address that in other ways, but I don't want you passing out and hitting your head. It's much more important that we keep your blood pressure up and that your brain is able to function and that your blood pressure isn't down here. So in my opinion, when I'm counseling patients, I usually tell them, drink as much water as your neurologist thinks that you need to drink to keep your blood pressure up and keep everything else functioning. As Dr. Poston mentioned, also dehydration will lead to constipation, which is going to make your bladder symptoms worse. Also, dehydration will actually make your bladder symptoms worse because your urine's more concentrated, and so that's irritating to your bladder as well. So to answer that question, the water is important.
Yep. So I'm going to keep it on you because that seemed like the bulk of the questions seemed to go to urology, and I'll let you sort of pick. There's some themes in there. I tried to cluster some of the themes together. So why don't you take? Yes, go right ahead.
One more water comment.
Yes, please. It's my favorite topic. So
yes, no, it's fine. Increasingly, there are yes, we enjoy some water here. Again, there's some suggestion that salt and water and sugar together enhances the sodium retention and the volume appreciation. So I tell people I'm skeptical about Gatorade because anything that's neon green can't have everything good inside. But there are online dehydration formulas that actually were developed for hydration in third world countries prone to cholera, and those have been extremely effective for maintaining hydration. So it's not only pure water, but also the salt and sugar combination that enhances the sodium retention and helps to maintain the intravascular volume, which keeps the blood pressure up.
Yeah, so some of those products, so that our patients can know about those, might be Noon, for instance, N-U-U-N. You can find that at sort of health food stores. Some of the other products that can be good, sometimes Smart Water can have a little bit more electrolyte solution in it. And then simply maybe taking salt tablets, which I know many of you have heard your neurologist tell you about, or mixing salt in your water can be helpful. I'm a personal fan of tomato juice as well, because I think it's an easy thing that has about 1 gram of salt in it, so you're getting some salt in there as well with something like tomato juice. Or salty meals, chips,
Yep.
nuts.
Yes, we're the only group of doctors who recommend salt to our patients. So okay, back to the bladder. So pick one of your topics and dive right in.
So I've kind of talked a little bit about a couple of the presentations that generally come in my patients that have neurologic conditions. So I've talked about overactive bladder symptoms of frequency, urgency, incontinence. Some other things that I commonly see is incomplete bladder emptying or urinary retention. And generally that is due to the bladder no longer functioning properly, so it no longer contracts when you go to the bathroom to pee. So those patients are often pushing or straining to push the urine out, or they're credaying, which is pushing on your bladder to push the urine out. Sometimes it's due to a sphincter that doesn't relax when you sit down to pee. So the bladder is contracting as hard as it can, but the sphincter isn't relaxing. So there's some dysynergia, and we see that with the colon, we can see that with the bladder as well, or with the bowels, and you see that with the bladder as well. And so some of that testing I talked about before helps us to differentiate this, because the treatment's slightly different. But the reason I mentioned the incomplete bladder emptying and the voiding difficulties, that it's often related to urinary tract infection. So if you don't empty your bladder well, the urine sits in the bladder stagnant, and bacteria is able to reproduce and cause an infection. And so these patients often have rounds and rounds and rounds of antibiotics due to these infections. So I have 2 questions that are related to that. One says, UTIs and bladder spasms are terrible. How can patients, caregivers avoid and treat UTIs and minimize bladder spasms? My wife describes bladder spasms as worse than childbirth, and they can be very painful because the bladder is a muscle and it contracts, and it can be like menstrual. Some patients say it's like menstrual cramps. Some say it's as painful as labor pains. The other question that's related to this, and then I'll answer, is my wife experienced frequent bladder infections resulting in almost constant use of various antibiotics. The outcome was the infection wasn't resolved. Digestion was adversely affected, dehydration, which negatively affected management of low blood pressure. Is there another approach to break this cycle? So the answer to these questions is UTIs are very common, and they're challenging to treat in patients that have neurologic conditions. So I always start by making sure that the bladder is emptying properly. If it's not emptying properly, we need to find out why, and then we need to treat that, because that's the kind of source of the problem. Beyond that, there are a number of prevention strategies that we will often employ. And so that involves things like cranberry pills. So cranberry pills we don't have great evidence for. There are some studies that show that they work well. There are others that show that they do not work well. We will often try them. The way they work is that they have this active ingredient called PACs that actually align the lining of the bladder and keep the bacteria from sticking. And they also coat the bacteria themselves. So that when you drink and urinate, then the bacteria should get flushed out. So sometimes that works well, sometimes it doesn't work well. It works best for E. coli. Other options are D-mannose powder 2 grams per day. That's also a supplement that you can get on Amazon, or you can get over the counter in your grocery store or your pharmacy. And it works similarly. It helps to keep the bacteria from sticking and to flush out of the bladder. But again, the important part is the flushing out of the bladder. The bladder has to get empty. Another treatment option is probiotics. Probiotics, there's mixed evidence for that as well. I generally tell patients to take probiotics while they are on antibiotics to try to help with the gastrointestinal symptoms that one of the question askers mentioned on their card here. And so that's where probiotics fit in terms of prevention. There are some studies that show that there are some vaginal suppositories of probiotics that can be effective. They are available in Europe, but they're not available in the United States. One of my patients told me the other day that they found it on Amazon. So I think it's worth trying and seeing if it helps. Beyond that, we have prescriptions. So we have things like methanamine. It is a medication that is an antiseptic for the urine. So it's not an antibiotic, so you don't develop all of the GI side effects. You don't develop the resistance to antibiotics. And what it does is it doesn't kill the bacteria, but it keeps it from reproducing. It produces a terrible environment for the bacteria in the bladder. And I've found that it's very effective, especially for my patients that don't empty their bladders well, because then the medication can concentrate in the urine there and keep that bacteria from reproducing and causing an infection. Beyond methanamine, so the brand name for it is Hiprex, Hiprex, Hiprex. And then beyond that, if it's a woman, then we can try things like vaginal estrogen cream. There is level 1 evidence that vaginal estrogen cream helps prevent urinary tract infections. And how that works is that when a woman goes into menopause, the loss of estrogen, the pH in the vagina actually changes. It goes up. So it becomes a better environment for bacteria. And this goes for all women, neurogenic bladder or not. And so using the vaginal estrogen cream actually brings back in the good bacteria, the lactobacillus. It then drops the pH in the vagina again and reduces the number of bad bacteria that actually cause urinary tract infections. So we have multiple studies that have shown that it is effective. I tell my patients it's kind of like wrinkle cream. You don't put it on once and then it works. You have to use it consistently in order for it to work. So that's another option. And then beyond that, the other thing that we have great evidence for, obviously, is antibiotics. So a low-dose antibiotic that you take every day. And generally, for me, in my practice, that's a last resort. We try all the natural things first because the antibiotics have side effects. Antibiotics, over time, you can develop resistance to. So we try all these other options first, and then we move on to a low-dose antibiotic that you take daily. So that's a quick answer for some strategies.
It's such a hard area, the issue of infections with the bladder. I'm going to ask you just one follow-up question on it that we had gotten online before. At what point do you think about a catheter in order to either avoid these current UTIs? Does that make it worse? Does that make it better? We get this question a lot regarding the idea of a permanent catheter, particularly in the setting of these recurrent infections.
Right, so great question. So there are 3 options for catheterization. There is clean intermittent catheterizations where you have a little catheter that you insert into the bladder a few times a day to make sure that the bladder is getting empty. That is always the preferred method if you have a caregiver that can catheterize you, or if you're able to do it yourself, because you don't have something sitting in the bladder all the time that can potentially allow bacteria to stick and to reproduce. So clean intermittent catheterization is always best, and it is a very effective way of getting the bladder empty and potentially helping reduce infections. The other option is a catheter that goes into the bladder and stays in the bladder, a Foley catheter that stays in generally for 4 weeks, and you need to go in or have a nurse change the catheter every 4 weeks. That is that is not the best option. That's the least, that's the option that we do not like. The reason for that is because it sits in the urethra and can cause issues with the urethra over time. So it can cause erosions, it can cause tearing, it can cause stretching of the sphincter and issues with incontinence. So that is really a short-term strategy. It's not something that you want to have for months and months and months. Okay. The third option is a suprapubic tube. So suprapubic tube is done where we during a short procedure where we numb the skin in the lower part of the belly right over the bladder, and a catheter is inserted there. So it's a lot more comfortable than a catheter that goes into the genital area, and it also eliminates that issue of damage to the urethra and to the sphincter, and then also empties the bladder very well and helps reduce infections in that way. Who needs a catheter? So anyone who is not emptying effectively and we can't manage it with medications. There are a few patients that we can manage with medications that have urinary retention, and generally those are ones that have an enlarged prostate or something going on with the bladder neck and the sphincter. We can give an alpha blocker like Flomax, maybe some of you have heard of Flomax, something like that to help relax that and allow that person to safely push the urine out or to contract and empty the bladder that way. But most patients, unfortunately, need some type of catheterization in order to get the bladder empty. And the last category of patient that needs catheterization is the patient that that has a stiff bladder, that has developed a stiff bladder. The bladder should stretch to allow urine to be stored, and if that doesn't happen, then a lot of pressure builds up in the bladder, and that pressure goes back up towards the kidneys and can cause significant damage to the kidneys and cause kidney failure over time. And so if a patient has that issue, then catheterization is needed to keep those pressures down in the bladder.
Fantastic, thank you. So we have about 15 minutes left, and I know there are some themes with some of the questions. We really dove into constipation, but I got several questions about the opposite side of things. Bowel incontinence, I just got one about, as well as diarrhea or flipping between those. Could you address that? Because I realized I focused heavily on constipation, but that's not always the GI problem at hand.
Sure. Although to me it is often the problem, even with patients who are complaining about diarrhea. So about the diarrhea in patients with neurological disorders, a couple of common and really well studied and well known etiologies or reasons for diarrhea. One is small intestinal bacterial overgrowth, or where we have not really established a good motility because of the abnormal nerves in the GI tract. What happens is that the bacteria that are normally exist in our colon will overgrow in the small bowel. And so as the result of this overgrowth, we can get severe episodes of diarrhea associated with abdominal cramping, sometimes even nausea, and explosive diarrhea to follow. These conditions often is addressed by a short course of antibiotics, and the diarrhea that is because of this bacterial overgrowth responds very well to the antibiotics. However, because the pathology remains to be there, often this is a recurrent problem, and so the diarrhea may be well controlled for a couple of weeks, and then after a couple of weeks or months, we may have recurrent episodes of diarrhea, and a recurrent course of antibiotic again may be needed. So for some patients who have frequent episodes of of bacterial overgrowth, we have these patients on rotating antibiotics. They may need to be on different antibiotics to really avoid the resistance, maybe the first week of every month, and we will be switching between a couple of antibiotics to keep the symptoms under control. It's very important to really address this issue because if unaddressed, it can cause malabsorption and vitamin deficiency and weight loss and significant consequences. So it has been studied in patients with neurological disorders, and 50% of the diarrhea have been noted to be as a result of this. If someone is not really happy to just get the treatment without testing, we also can offer testing for what we call SIBO, small intestinal bacterial overgrowth, and this is by a breath test. Basically, you will come, have a drink of the sugar, and then we will collect your breath every 20 minutes for a couple of hours and measure the amount of the hydrogen that is collected in your breath. And so it's a very easy, non-invasive test that can give us the answer. This is one common cause. The other cause that is often very confusing is basically overflow incontinence and diarrhea. So this is in a patient that has been having constipation for several years or several months, and all of a sudden, rather than having constipation, they are coming and asking for management of diarrhea. They have constant diarrhea, no control over their symptoms of diarrhea, often associated with significant impact on their life because they cannot really hold their bowel, and it's constant soiling and need to wear a pad all the time. And this is really because of the fact that the rectum is impacted with the stool. So the unaddressed constipation is causing the fecal impaction, which is the stool that is stuck in the rectum. And so the stool that is sitting on top and is coming from the top of the colon will be seeping around this impacted stool constantly without really having any control and causing this constant diarrhea and overflow incontinence. So when we are dealing with this patient, we really want them to be on laxatives, and this is often hard to convince a patient who has diarrhea to go on laxatives. But truly, the treatment is with the laxatives, and we start with suppositories and enemas because that impacted stool can be very hard to come out with the oral medications, and therefore here is really focusing on the use of suppositories.
Yes, go ahead.
So I have a couple of questions. I'm not sure.
Was the other one?
So I guess there is a question about the treatment of constipation, but maybe later. And also there are two questions about CBD and THC.
Yes, we had a couple questions about that. If you wouldn't mind addressing, that would be fantastic.
Right. So again, nausea and vomiting is also another common problem in many of the patients with neurological disorders. It can be multifactorial. Many reasons can cause these symptoms. It can be because of the delay in the gastric emptying, because of the vagal problem or autonomic dysfunction, very well can cause delay in gastric emptying, and or simply just the functional pathology. So marijuana is well established to really know to improve the symptoms of nausea and vomiting. And we have even in the form of the dronabinol or marinol, which is the pill that we often give for patients with terminal pathologies to improve their nausea, vomiting, and stimulate their appetite. However, smoking or basically the recreational marijuana has two components, the CBD and the THC. And we know that the THC, although it can really improve the symptoms of nausea and vomiting, It can cause the symptoms that are mimicking cyclic vomiting syndrome, which are constant retching and vomiting. Every couple of weeks, these patients are having a really severe episode of nausea, vomiting, and these episodes are very significant. They often end up in an emergency department. These patients do not really respond to any over-the-counter medication or even prescription medications. Often the hot shower is the only thing that will take care of the symptoms of nausea, vomiting, and this is truly induced by the marijuana, and stopping marijuana for a couple of weeks will take care of these types of symptoms. However, the CBD part has none of these side effects, and so if it's really needed for nausea, vomiting, or stimulating the appetite, it's better to use the CBD and try to avoid the THC, especially if you have sensitivity to it.
Thank you. So we have about 5 more minutes, and there are two questions that I want to make sure we address. So the one is regarding the inner stem. There were multiple questions about this.
Yes, so the inner stem, we kind of call it the pacemaker for the bladder. It's made by the same company, Medtronic, that makes some of the deep brain stimulator pacemakers. So it works. With the wire. Yes. So it's also a treatment for overactive bladder, so frequency, urgency, and urgency incontinence. And so in the general population, non-neurogenic patients, the success rates are somewhere around 70%. They're in the MSA population. I don't know of any studies looking specifically at MSA, but I know there are some studies looking at Parkinson's and MS, which is a little different, but looking at Parkinson's. And also, we're currently doing a review of our data at Stanford and looking at our success rates with InterStem in the Parkinson's population. And what we found is that it's effective about 57% of the time. So I would say about 50-50. With that said, you want to make sure you've had the bladder test to make sure that you've determined that you are an appropriate patient for this treatment. And then I think it is worth trying. It's worth trying having the device implanted. There's a test phase, generally of 1 to 2 weeks, where we have you keep track of the frequency of your urination, the urgency, and the incontinence, and see whether there's an improvement or not. And if there's not an improvement, then the device is removed. And as part of the question, someone asked about Botox as well, which is the other advanced therapy for overactive bladder symptoms. And I find that Botox, and studies show as well that Botox is probably a little bit more effective for neurogenic bladder. The general concern with Botox is that if you're someone that voids or urinates on your own, there is a risk of developing urinary retention, because what Botox does is relax the bladder. So in some patients, it may relax it a little bit too much and cause retention where you require a short period of catheterization. But if you're already catheterizing, then you can be really aggressive with the Botox, and I find that it's very effective in helping with.
And because of that, for the patient who is independently voiding, do you do as we do in the movement clinic and start at low doses for those patients?
Absolutely, yes. So we start with the lowest dose and see how you respond to that. And if you do okay, but we don't have quite the effect that we want, then we go a little bit higher. And we find that often if you did okay with that first one, you're probably going to do okay with the higher dose as well.
So I want to bring us to the end here in wrapping things up, because we're getting close. I believe I'm looking for Cindy here. I was supposed to wrap up around 12. Is that correct? I was supposed to wrap up around. We're okay. And I do apologize that we have not been able to get to every single question. These were fantastic questions, and I hope we tried to try to get the main themes out. There's a couple comments that we had left a pulmonologist off the panel. Yes, we did. I apologize. I do think that would be a great idea in the future. I do believe that that our sleep doctors address some of the pulmonology, and I'll say my personal approach is I usually first, if I think there are respiratory issues, oftentimes go through the sleep doctors and sort of address those issues, and then let the sleep doctors determine whether the pulmonologist is needed and go in that route. But as a big picture theme, I'm going to kick this back to Dr. Santini, because a lot of these questions came from, that's great that you've got all of these wonderful specialists, but I have found that my doctors don't interact with each other or talk to each other. I have found that I don't necessarily have access to some of these specialists. What do I do when I am in that situation? How can we facilitate this team approach? How can the patient or the caregiver be an advocate for this team approach if you don't feel like you're necessarily getting that from your doctor? So I'll let Dr. Santini sort of end us with that theme. How can you bring this team back to your care?
Yeah, so this is something we hear a lot, and this is something I'm acutely sensitive to. So I'm a physician who goes internationally and does global health work quite regularly. And, you know, the distribution of resources and resource limitations in healthcare are very, very important to discuss. So I am aware of that. The way that our healthcare system really works is that oftentimes highly subspecialized individuals who have the advanced training, they might be at what we call academic institutions. Those are institutions that are associated with a university, and they're usually in larger cities. So it is true that living a little bit more rurally or having difficulty traveling to those cities does limit sometimes the resources. That being said, there are fine doctors all over the country. And so what I find is that there are several ways that we can make this communication better. And for providers who really don't feel like they have the specialized training, a lot of education can be done so that you guys get the best care that's possible. So the number one thing I would say is in general, all of us send our notes to one another. Hey, this is what I did at the last visit. Hey, this is what we figured out, and these are my recommendations, and what do you think about that? So we have ways of messaging each other and sending each other letters. Oftentimes in the letter, because they can look generic, I may specifically bold in the beginning paragraph of the letter, see my recommendations below, but these are some things I really need your help with to address in between our next visit or the next time you see the patient. So that's number one. And so you want to be asking your physicians, hey, are you able to send a letter to my physician, or are you able to send a message to my physician letting them know what we did at this visit? And I guess let me take one step back. Because we are subspecialists and because we do have a lot of patients, not just with MSA, but with many neurologic disorders that need our care, it is true that sometimes we say, hey, I can't see you for 3 to 6 months, right? And so you think, oh my goodness, what am I going to do in between all of that time? So that's another reason why the care team is so important. So number one, make sure that your physician is sending a note with every visit. But sometimes, and this happens to me all the time, I say, I never received that letter. I never saw that letter, right? Because our hospitals are big and it's difficult sometimes to receive the mail or whatever the nonsense logistical reason is. But because of that, I sometimes ask my patients who are having difficulty with the communication to get a copy of my note from today. So I can send it very easily through our electronic medical record, but if you can't, you want to get it from the medical record department. If you are able to carry a note or a handwritten note, all of our patients in our clinic leave with a salmon-colored sheet, and we write down the recommendations, and I say, take this this sheet to your next doctor's appointment so that they can see my handwriting and what I've said for the patient. So if the communication's not happening electronically or via mail or whatever, you physically hold on to your records and bring them to your appointment. So you can say, hey, by the way, I saw my neurologist and this is what they said. Because I can't see my patients as often as I would like, we often will partner with a community doctor or community neurologist. And what we can do is in those notes, we can say, hey, I'm recommending this at this visit, but if this doesn't work, you might want to consider trying this. So if you have that note and you've read those words that I wrote down, you can say to your neurologist locally, hey, the doctor, said this may work, but it hasn't really worked. And look, they put something else down here. What do you think about this, right? And have a discussion about that. So those can be ways that you can really take ownership of your disease and therefore get better care. Let's see, I wrote down a bunch of notes about this because this comes up a lot. when all of these handwritten or typed out notes are really not doing the trick, that's when a phone call is needed. So, I think that if you ask your physician, hey, would you mind calling, this is the other physician's number, would you mind calling them and talking with them? There's not been one physician that I've spoke to on the phone where they don't care about the patient, where they're not willing to try things. Oftentimes they just need a little bit of guidance, and they're very excited to hear the partnering. The other thing that helps with phone calls is I get clarification, because sometimes there are things, we speak in medical jargon or we speak in terms that you might not know, and so we're able to talk one-to-one on the medical terminology and really get clarification about what's going on. I'll say, why haven't we tried this, Dr. So-and-so? And they say, really, that would not be good because of X, Y, or Z. And I say, oh, thank you so much. I didn't even realize that. So a phone call can be really, really helpful. You want when you're having trouble, you want to ask your doctor to advocate for you. And these are the ways that they can do it. Say, look, I'm really having trouble and I need help. When your doctor's too overwhelmed, ask if there's a social worker that you can perhaps, or a care manager that you can be referred to who can help to coordinate your care. And then that brings us back to the good primary care. So primary care physicians do sometimes see their patients a little bit more often, and that can be helpful for us. And if you're really unhappy with your primary care physician, if you feel like you're not being listened to, you can always request to get another one and see if maybe switching providers can be helpful to you as well. That wouldn't be the first step. You want to really try and see if you can work with your doctor. But if you can't, even ask your neurologist or one of your other specialists to say, do you mind referring me to someone in your institution? And then that way we can discuss. And then finally, when you're really having trouble traveling to doctor's appointments or other things, there are other places you can get information. So for instance, all of you made a huge effort to be here, and I think hopefully you agree that you've learned a lot from the last day and a half or so. So forums like this can be a really great way to get information, to get resources. Webinars are also ways to do this where you don't actually have to leave your home. Are we live streaming it?
We are, yes.
Yeah, and for instance, this is a conference that you could have engaged with while at home. So we're live streaming this conference as well. And also support groups can be a final way. Now, I do hear patients sometimes saying to me, hey, I don't want to go to that support group because I don't want to hear about what's going to happen to me, or I don't want to see how, I might have that condition that I don't have right now. As I mentioned before, everybody has a different disease. Even though it's named the same thing, you all have a different disease course and different symptoms and different parts of the autonomic nervous system that are involved. And so support groups are an immensely huge resource. And when my patients aren't attending them, I do bring it up every visit. You might not listen to me, but I really think it's important. And the leaders of the support groups are incredibly knowledgeable and often have connections with other community resources that can be helpful to you. Dr. Friday has already mentioned to you about resources at the VA, but interestingly, there are other community resources out there. And even if they're not specific to MSA, they are specific to people who have health issues. And so we can tap into those resources as well. Dr. Poston, I'm going to throw this back to you in case I missed any possible ways.
I think that's all fantastic, and I again just really want to encourage all of you. All of us. So legally, when we see a patient, we have to write a note. So you're not asking your doctor to do extra work to send that note to your other doctor. It's part of the legal process of seeing a patient in clinic is that we have to write a note. All that note just has to get communicated to your other doctors. And if you don't feel like it's happening in the normal system, then you're the one who hand delivers it and gets a copy of it and brings it to the next place. It's not the ideal system, but sometimes that is the way that it happens. I do want to just give one final plug to a webinar that's going to be happening in November. One topic that we didn't really get into so much during this conference is the issue of cognition and memory and hallucinations that can occasionally occur. It's because it's not as common in MSA. That's why I didn't really focus any of our panels on this. It's really not one of the more common common symptoms. But because it can happen, we wanted to do a special webinar. That'll be happening on November 12th, and I will be coming up with the slides at some point between now and November 12th that I will be giving during this webinar. So please consider passing that along and being part of that. So with all of that said, I want to thank my fantastic panel. Thank you guys so much for being part of this. And now Cindy's going to tell us where we go for food. Oh, and don't forget the survey. If any of you, I have little, you can bring that home with you. So I have little cutouts with the website. If you want to just grab it and bring it home with you, it'll also be on the website, and it's also up there. So please take the survey.
Told you she's good.